Well, today I'm excited to talk to Dr. Shawn Watley, who is the author of When Politics Comes Before Patients. It's a new book out that really looks at all the problems in our healthcare system. And so Dr. Watley is a former president of the Ontario Medical Association. He's a Monk Senior Fellow with Macdonald Laurier Institute, and he's a family physician in the Newmarket area. So Dr. Watley, thanks for your time today.
Thanks for having me, Colin.
I got to tell you, I really appreciated going through your book, and I think you owe me a pen because when I read books like this that aren't fiction, I like to do a lot of recording and or underlining of facts and figures that are interesting. And I think I went through about a pen going through all the interesting stats and figures that you've dug up for this. But before we talk about sort of what you see as some of the fundamental problems with our system, I want to ask you if you could just tell us about your journey. How did you come to write a book? I think a lot of people, they get into healthcare to, help out patients, rather than looking at something as ambitious as, the need for structural reform. Could you tell us about sort of how you came to this position?
Well, thanks for asking that question, Colin. I often ask myself the same question, and I think my wife does too. I started out as a regular doc, just in the trenches. Actually, I started in emergency medicine, and it was after about 5 or 8 years approximately, I got tired of cringing every time one of my neighbors would say, "Oh, I was just in your emergency department," and I'd kind of cringe and then go, "Oh, how long did you wait?" And in those days, it was really, really common, 6 hours, 8 hours just to see the doc. And mixed with that and some staffing trouble, we didn't have enough docs to even fill a schedule. I got involved in leadership and so became chief and medical director, and then progressed on to medical program director. And just one thing leads to the next. As like so many other docs who've gotten involved in leadership and medical politics, you get involved out of a desire to try to fix practical problems for patients. And so 20 years later, you look back and you realize, oh my goodness, so I've been working in Emerge and now working at the provincial level and Ontario Medical Association and Canadian Medical Association, and wrote a little book on emergency wait times, and now looking at how we can improve the whole system itself. And it's fun, it's fascinating, you get obsessed with it, and it's like a virus, you can't get rid of it. But hopefully it's drawing attention. It seems to be, and I appreciate you taking the time to read it. I owe you, I'll give you 2 pens.
Don't worry about it. It's been great to go through it. I've had an interest in healthcare for a long time now. It is fascinating to look at it. It's just such a big issue in many people's lives, and at some point we all need the healthcare system, so we want to make sure that it's there. So it's been interesting going through your last book and now this one, and I look forward to, you've got another one coming up that you're thinking about. We'll talk about that in a minute, but I want to ask you about sort of recognizing that it wasn't sort of anecdotal problems that you saw on a daily basis, but what were sort of some of the signs that you saw that this system needs, it's a bigger issue. It's widespread. There are problems, very systemic problems, not just in Ontario, but in the rest of the country that need to be addressed. Like how did you kind of come to that conclusion that it was bigger than just sort of maybe what you had come across on a daily basis?
Yeah. I think part of it came from the change we tried to do in the emergency department first. We were very successful at changing our own department. It took about 3 to 5 years, and then it takes even longer than that to get this new culture of not letting people wait and treating every single person as though they were our most privileged patients. And privileged patients are friends and family of people who work in the department, or local dignitaries or celebrities, politicians, that sort of thing. Those kind of people never ever waited in the waiting rooms. And so we thought, well, why don't we get everybody out of the waiting room? And so we really could make a fundamental transformation to how patients flow through our particular department. But at the end of my first book, I said, you have to get political. You have to get involved, get on your foundation board, get on your hospital board, sit on committees, because this is where the decisions are being made that impact how patients flow through the system. And it's not that I grew up with an interest in politics. I didn't. And so I've sort of had to learn this all over the last 15 to 20 years. But I realized that is where decisions are being made. They're at political tables, at committees, at places you didn't even know existed before you actually got involved into thinking about how the system runs. But important decisions are being made there that practically impact how patients access care. So when a patient is sitting in a wet diaper in
Mhm.
a hallway because there are no beds and there's not enough people there to help him or her get out of their wet diaper, that results from a decision made by someone or some group somewhere. So, like Marie Deschamps said, Supreme Court of Canada Justice, in her ruling or her opinions that she offered in the 2005 Chihuly case, she said that the wait times, therefore, in the medical system, Medicare system, are real and intentional. And so we've got better at talking about the reality of those wait times, but we haven't talked about the intentionality of it. Someone actually decided to create a system or allow a system to exist that leads to these kind of outcomes. And so it's all of that together, the frustration at not being able to see the change that we want, not being able to have resources that we need to give patients who are suffering, and then realizing that decisions are being made by other people who don't know anything about healthcare,
Mhm.
um, uh, because they're trying to achieve budget targets or performance targets, or who knows what other reasons. They're trying to win elections, a whole list of different goals they're trying to achieve that end up compromising the care and ultimately the dignity with which we provide that care to patients. And that's really where my motivation is coming from. It breaks my heart to see how people are being treated in our system.
And we do struggle with output in terms of the quality of care provided to patients on an international basis, right? Like you and I were talking before the interview about the Commonwealth Fund's report from the United States, where Canada ranked quite low compared to other countries, don't we?
Yeah, really, I think the tipping point came in 2014 with the Commonwealth Fund's first study, Mirror Mirror,
Mhm.
and it looked at the top 11 health systems in the world, and Canada was very happy. Canadians, we were very happy that we didn't come last. We came second last. We were ranked one place above the United States, and they looked at cost and waiting and equity and the number of people covered and access to care, that sort of thing. They repeated this study in 2017, and we moved up one place from the bottom. So now we were third last, and France had slipped. But that's only one organization producing that information. There's also OECD studies. People can Google the Canadian Institute for Health Information. They have a lot of great data showing how Canada performs compared to other countries. Maybe I'll wrap up with saying data is important, but no matter what data you present, people will always say, yeah, but we're trying to fix it. I mean, even when Bernie Sanders was here in Toronto for his pre-election healthcare visit, and he was, just oohing and awing at how wonderful the Canadian Medicare system was, and he said in his interview, he said, "So I hear, you guys have wait times, right?" And the person he was talking with said, "Yeah, yeah, no, waits are pretty hard." He said, "But I also hear, but you're working on it, right? You're working on it." So, and the New York Times said, Bernie Sanders takes a glass half full approach. And so it doesn't really matter how people perform or how systems perform, as long as your heart's in the right place and you have the right intention. So we talk about politics of intent when, political philosophers write about it. We have to move beyond intention. I mean, when someone is sick and desperately in need of care, they expect to get the care that the government has promised to provide. And that's the crisis, I think. You can't tell me that you're trying to do better after 50 years. We have to do better. People are suffering. And again, that speaks to, that's what made me put up with 5 years of writing and all these policy books I had to read to put this book together.
Well, the Bernie Sanders anecdote, I like that. It kind of reminds me because you do hear American politicians looking at the Canadian model, and it reminds me of, uh, if you think about running a sprint. I haven't done a sprint in a long time, probably since high school or junior high or something like that. But I know that if I came in ninth place or 11th place, as you mentioned, the Commonwealth Fund had 11 countries. The US came in 11th, and the last report of theirs showed Canada came just ahead of them in ninth. if I'm coming in 11th in a sprint, I'm not talking to the guy in ninth place and asking him for advice. You go to the guy in first or second or third, say, how are you such a great runner? Do you have any advice? What can I do? And when I think about that list, the countries that are ahead of Canada, they still have that universal component that Canadians hold dearly, don't they? The idea that in those 8 countries ahead of us, you're going to be helped out if you need medical care, whether you're rich or poor. The system's going to be there for you, aren't they?
Absolutely. We do not need to compromise on the concept of universality, which means every single citizen gets care. The question, the debate is whether we need to have the government as the only way to provide 100% of that care and have the government manage it all. So when we started back in the 1970s, the government simply paid for it, right? There was public payment, private practice. And this was this great myth that Canada had figured out this new third way where we could have our cake and eat it too. Docs would still be able to run the practices and do what patients need, and the government would just pick up the tab. Well, that dream ended around 1977 when the government stopped their blank checks and stopped their block grants to the provinces. Essentially, they would just say, "We're going to pay for 50% roughly of
Mhm.
whatever the provinces would spend." And so then the provinces had to say, "Oh gosh, now we can't take credit for a new hospital in every little community and new services here, there, and everywhere." And so they had to really start ratcheting back on services and access and beds, and that's when the micromanagement started to happen, and this whole wave of managerialism, which really had crossed all of Western civilization, shall we say, since the 1950s, but it really hit medicine in the 1980s and then for sure into the 90s and thereon. And so now patients don't realize that the care you get, yeah, sure, you're working it out with your doc, should we get this, should we get that? But ultimately, what you can even choose to get or not get has been decided by an expert manager somewhere.
Mhm. No, I think you're right. There's way too much bureaucracy involved, and I talk about these stats. I'm serious when I say that I was running out of ink because he had a lot of good ones. One of the ones that surprised me was you talked about a figure from Ontario, the more than doubling of the number of bureaucrats over, I think it was like a 15-year period or something like that. Like it just seems like the bureaucracy continues to expand. Another stat you had was from the Canada Information CIHI, that health body that looks at Canadian data on healthcare and how they had 700 staff. It just struck me as 700 staff just looking at it. It's like the government went off and created this little bureaucracy to look at the system, and now it's grown to 700. It just seems like it expands. And you make the point in your book that we have more bureaucrats, people pushing paper and pens around than we do see in other countries. And so I want to come now to the something that 2 points you note in your book. One is that Canada has these world famous waiting lists, that our waiting lists are quite long. But at the same time, you note in your book that Canada spends uh, typically among the most in the world when it comes to healthcare. So we're spending a lot, we're not getting results. Other people have raised this point in the past as well. What do you see as what's stopping us from reform? What do you think is sort of the impediment to really having some serious health reform that could help patients in this country?
So I appreciate you asking the easy questions, Colin.
Just that little
So,
one.
just a small one. He told me before the show, this is 20 minutes. We'll just make your answers crisp, eh?
The 5 words to answer that question. What's the
That's
problem?
right. So why are we spending so much? How come we can't change, and why can't...
Yeah.
No, I love it. You nailed it. I mean, this is really the crux of the issue, right? And when we look at our comparison to other countries, again, we're spending more and more. We're usually in the top five for spending, and sort of in the bottom two or three. And when you look at least the OECD countries for performance, it's difficult to know where to even start with that question. I mean, costs are being driven in large part by our neighbor to the south. So our neighbor to the south determines wages and salaries. And so you have to remain competitive, or else we would lose all of our nurses and doctors
Mhm.
to the South because they're paying so much more than us. So that's part of it. But I think that's a bit of a cop out because other countries face similar situations and also a mobile workforce. I
Yeah.
think part of the reason we are so expensive is because we are so insistent on trying to fit our whole system into one way and only one way of doing things. I
Mm.
mean, there are plenty of studies showing that even the way you pay a person, for example, if you pay someone by the hour to paint a wall in your house, or
Mhm.
you pay someone by whether or not they get the job done. So I'll give you $100 to paint the wall, or I'll give you $10 an hour to paint the wall.
Mhm.
You often end up paying more for the person who's painting by the hour. Now, the person who's being paid by the hour will say, yeah, but my quality is so much better. Okay. So you have to make criteria to say that no matter what, the job has to be done with the equal outcome with respect to quality, or you get fired, or you don't get called back, or whatnot. So the thing to the argument that, oh, I'm doing such so much better job if I'm being paid by salary, is
Mhm.
just simply not there. So that's only one example. How we pay people determines the efficiency we're able to deliver, and the amount of productivity we're able to get out of that. We could apply that same lens, and this is only one lens we're looking at, but we could apply that same lens to how we pay hospitals. Do
Mhm.
we pay them with blocks of funding that they have to stretch out for the whole year, something called block funding for the whole population they serve? Or do we have patient based funding where we pay them a small incentive to actually see another patient? Now they're incentivized to actually make sure they get patients in and get them treated. We could also talk about the way we got rid of our accounting departments in the 1970s for hospitals. So case costing is actually very, very rare when it comes to a hospital because it costs so much to have all these accountants around documenting exactly how much a appendectomy would cost, or how much a visit to an emergency department would cost. And so we really don't know how much things cost. So if you're coming from a business environment into a publicly funded system, you go, wait a second, you're spending all this money on nurses and doctors and tests and labs and x-rays, and you don't know how much it even costs
Mm.
to do one appendectomy. You take out someone's appendix in your hospital and you say, yeah, no, we thought we'd save money by getting rid of that department. And this is well known, and deputy ministers of health will speak to this, and I quote them in my book saying this. So those are just a couple reasons why our system is so inefficient.
Mhm.
People who defend the system will say, well, it's all because of high salaries, because of the evil neighbor to the south. People who want to criticize the system will bring up examples that I give you. For example, we don't even know how much things cost, and we have no competition. It's a monopoly. Monopolies are inherently inefficient. But I better stop there since
Yeah.
we only have half an hour.
But it's the I want to get at the what's the barrier, because I've heard this argument in the past too, that we should block funding is inefficient. You raised other points as well, like that could help the system. Why aren't we taking that next step in Canada as a nation? What do you see as the barrier to reform?
Well, I think in large part we've tied Medicare, we've tied the whole healthcare industry to politics. It's tied to a political system, which leads to the title of the book, When Politics Comes Before Patients. And so, if I'm an elected representative or I'm running for office, I need to have the support of my constituents. And so I need to have them believing or thinking that I'm on their side, that I'm promising good things, and that I'm doing good things. So I need to keep this sense that I have things under control inside healthcare, because we've connected healthcare to politics. Well, we know that only 4% of the population in any given year requires acute care. So you and I don't spend most of our lives in hospitals or ICUs or getting surgery done. It happens a couple times in our life for most people until we're very, very old. So Canadians go through their lives, 96% of us go through our lives believing that care will be there for us when we really, really need it.
Mhm.
And we have reason to believe that's true because we call our doc and, hey, I get to go see my doc in the clinic, and yeah, okay, I waited a week or a couple days or maybe even 2 weeks, but at least I saw him or her, and at least I got my x-ray. And so for all of the things that the bulk of the population needs, we feel that this thing is still there that we call healthcare. But it's only when you get really sick, or when mom and dad get really sick and now they're needing to wait for long-term care, and they're waiting 2.5 years for a bed in long-term care, or they're the ones sitting in a wet diaper in the hallway and someone comes by and says, no, sorry, I can't take you to the bathroom, you've got a diaper, I've got to run and do some other important work.
Yeah.
And so it's only when we start hearing those stories and being involved with the actual end product when it's really needed, that we start having political impetus to change.
Mhm.
I would argue that that's a bad way to organize a health system, to tie it so intimately to the political system. And so I would start there. I mean, there are lots of other reasons why we are unable to change, but I think that's the biggest one in my mind.
Yeah. So we need a much more informed uh, population in this country about the problems in the system, uh, the need for reform, and if I'm kind of covering off what you've said correctly, and I think also sort of the understanding that reform doesn't mean we have the U.S. system, but that we could look at countries outside of the US that are keeping that universality that we talked about before, but also embracing other ways of delivering healthcare that ultimately lead for better results for patients, don't we?
Yeah, so definitely talking on the performance end of things, but even before that, we were saying in the discussion before, and even with our Bernie Sanders comment, we we've agreed as a country that the politics of intent is
Mhm,
okay. As
mhm,
long as I'm really, really trying. I believe our current prime minister promised a family doctor for every patient in the country as part of his political campaign. Well, okay, so when are you going to deliver that?
yeah.
What are you going to do if you haven't delivered that? How are you going to deliver that? So, as Canadian voters, we should be demanding that. If you look at I believe it was the Finnish prime minister, and I put this in the book as well. He resigned when he was unable to deliver on the healthcare promises that he and his party made. He took the fall. He said, "You know what? We made a promise. We couldn't do it. I, in good faith, have to step down." For some reason, it's okay to just keep making promises on healthcare in Canada and not delivering on them. Smarter politicians are too nervous to actually make concrete promises like that. But when you make a concrete promise, and I think that's the right thing to do, so kudos to Trudeau for doing that.
Mhm,
But when you make it, you have to deliver on it. You can't just say, oh well, that was a campaign, and more important things happened, and now we have COVID, so what can we do? No, you need to live up to that. And I think we need to hold our politicians accountable to that. As far as the European approach, I think the main thing in Europe is they give citizens choice. You have the ability to choose, am I going to go with this public hospital or with that public hospital or with this not for profit private hospital, right? They're not making profit, but they aren't 100% run by the government.
yeah.
And so just having a tiny bit of choice within the system, in the same way that our most privileged patients get choice right now, we would be able to create some incentive, some sense of people could say, okay, so I could mail my letter with the post office, or I could mail it with UPS. And UPS maybe only still delivers 5% of the mail or whatever percentage they do. But now the publicly funded post office is being held to account by the performance people can see in the UPS office or the FedEx office. And so it doesn't take much to incentivize change within the larger system. But if you have a monopoly, and especially within that monopoly, if you have privileged access for some people, there's no incentive for it to change.
I think you're right. And I like that point that you make about the lack of choice in this country. And I think that's especially evident right now because of COVID-19. You have, we just put out a report today where we looked at how many procedures have been postponed, delayed. On the one end of the spectrum, you have maybe some people who weren't really affected by having, say, an MRI scan for sore shoulder postponed. But then on the other end of the spectrum, you've had people that have sadly passed away because their only choice was going to the government. The government said, we're shutting down these procedures. So they had to wait. You know, one gentleman in Alberta, he was waiting for pacemaker surgery for to have a pacemaker put in for his heart, and sadly he didn't make it because of the postponed operation that he had. So you have people being funneled to just simply one system. It's going to overload that system, but you're not creating that relief valve where they could go outside the public system. I want to just go on to one other problem that you talk about in the book, and that is the rationing that goes on in the healthcare system. Could you just tell us a little bit about how that works for people who may have heard the term but aren't familiar with what actually happens in terms of the rationing?
Yeah. So the R word is something you're not allowed to talk about in Canada. And it was the same in Britain with their National Health Service. The NHS is what the name they have for their Medicare system. It was the same thing in the 1960s, right? They were about 20 years ahead of us in building their system. And politicians and anyone in leadership within their system would give the public the impression that if you need it, you get it. No questions asked. This is what we're here for, right? We promise to deliver the care that you require. And what that did was that engendered a great deal of frustration for people when they come to the healthcare system expecting to get what they need when they need it and it not being there,
Mhm.
because there were competing interests, right? We had to spend some of the tax dollars on education and some on roads and some on the court system or wherever. And so it wasn't until the UK anyways got to the point where they could be very upfront about, yeah, no, we only have so many dollars to spend and we therefore have to cut off the amount of spending for X, Y, and Z.
Mhm.
And so they now write white papers on rationing and they write textbooks on rationing. And this is a real part of the system. We're not there yet in Canada. And like I said, in the Supreme Court decision in Julie 2005, right, that wait times are real and intentional. Well, intentional wait times are the practical outcome of rationing. So if we had zero wait times everywhere for everything, the public system couldn't pay for it, and certainly no system could pay for it if it was free at at the time at point of access, so first dollar coverage with zero wait times for everything, because people would just keep consuming and consuming. I mean, they wouldn't consume for fun, but they consume beyond the level of value that they're actually getting for the service provided. So double checks, triple checks, third opinions for anterior knee pain, repeat MRIs just in case. And we see some of this already in our system, actually a lot of it. But because we have these long wait times, that amount of redundant abuse isn't as severe as it would be if we had shorter wait times. Now, this sounds like an argument in favor of wait times. I am fundamentally opposed to wait times because of the pain and suffering and trauma that they cause. But
Mhm.
you asked for a concrete example of how rationing looks in Canada. The other kind of rationing we see that's a big issue is between urban and rural services. So downtown Toronto, you'll get quite a nice hospital to stay in with quite fancy hospital services. Part of that is because you have politically active people living in that community, but an even bigger element has to do with the hospital fundraising that the charitable foundations can run in hospitals. So the budget for a hospital foundation in these larger hospitals is often much bigger than the whole budget for a regular hospital out in a rural area or out in the community, and they aren't able to raise charitable donations in the same way. Well, charitable fundraising can go to capital equipment expenses, so renovations and ultrasound machines and x-ray labs. They're not allowed to pay for staff. Well, if you have a big fancy hospital that Bernie Sanders visited in downtown Toronto that's funded in large part, a significant amount of money is coming in through their charitable donations. and compare that to a hospital in North Bay or wherever. I'm just picking a name off the top of my head that doesn't have that robust charitable giving. Well, now they're trying to fund both their capital or their structural costs and their operational costs, so paying for staff costs out of the same budget, the same tax budget. So there's a huge inequity between high socioeconomic areas and lower socioeconomic areas, or urban versus rural. And I could go on just to talk about how not everybody's getting the same experience here in Medicare, and that is a form of rationing, geographic rationing, if you'd like.
Yeah, and one of the points that I was thinking about as I was reading your book, and your one of the sections where you talk about rationing is sort of the idea that hospitals get money for the year and they try and spread it out. And quite often you get to that March period where it's the end of the fiscal year, because that's the end of a government's fiscal year. And quite often I think you end up with like surgeons kind of sitting around twiddling their thumbs because there's no money left to do knee surgeries, hip surgeries, whatever the case is. And I often come back to again this thought of the rationing, but also the lack of choice. So you have these surgeons that are there, they could do the work, but the government doesn't allow patients to go outside of the public system, pay to get their knee done. They must wait because the government has politically decided to spend money on something else. And we talked about the inefficiencies in the system and so forth. So the whole thing, I think it just begs reform, and your book has reinforced that idea. I want to we're still fighting COVID as a nation. Obviously, that's had a significant impact on the healthcare system in different ways. But do you think that it has had enough of an effect to really get people thinking more and desiring reform? Is it pushing politicians towards reform too? Do you think COVID will have that effect, that will sort of be a watermark where we're now going to, as a nation, significantly spend time on health reform?
So I believe it was just last week. I believe it was Alberta announced a huge infusion of cash for healthcare in their spring budget. I think we're probably going to see a trend of provinces throwing money at healthcare, and I use that word with intention. Throwing is kind of a disparaging word, and that's the Canadian way, right? We run into a crisis, throw some money at it, and hopefully it gets better. It certainly is a politically safe thing to do. People get the sense that, hey, I'm pro healthcare. I'm here for you guys. I'm going to build this system that clearly wasn't prepared for COVID. We've been saying something like this is going to happen at least the 20 years that I've been involved in medical politics. I've been saying our system cannot cope with the volume we have every single December, January, February.
Mhm.
We're talking about canceling surgery, and we have headlines in papers, hallway medicine. The week before COVID hit, the city of Brampton declared unanimously at their city council, a state of emergency for hospital overcrowding. And then the next week, COVID hit, and that's all anyone wanted to talk about. And then this winter, we're blaming all the crowding on COVID. So I wrote a piece actually for MLI, Macdonald Laurier Institute, just a few weeks ago, saying that this is not fair, and it's actually inaccurate to blame all of the crisis that we're currently facing in Canada around healthcare on COVID. But we have 2.5 beds per 1,000 population in Canada.
Mhm.
In European countries, they have 4.7 beds on average per 1,000 population. In Germany, it's 8. In Japan, I believe it's 13 or even higher. When you look at Ontario, we only have 1.4 acute care beds per 1,000 population. So we've known this for ages. So that's one major issue. We don't have the capacity. However, we peaked at only 1,600, which is a lot, but still only 1,600 COVID patients admitted to hospitals in Ontario in wave two, like the worst wave, right?
Mhm.
1,600 patients who tested positive with COVID. We could debate whether or not they were all COVID cases. We'll just assume they all were sick with COVID, and that's the only reason they were there.
Mhm.
1,600 patients. Well, Premier Ford had already added 3,100 acute care beds to the system. So if all of those new beds were in one giant COVID hospital, it would be barely half full.
Yeah.
And we only had about 400 ICU patients. Well, we added 1,500 ICU patients.
Yeah.
And so if it was just COVID causing the problem, the beds that we already added should have solved the problem more than enough. But yet we're still under this massive concern. Our healthcare system's going to collapse. We have to flatten the curve again for a second time. Why don't we face the fact that our system clearly does not have the capacity to deal, or the resilience to deal with, a stress on the population? And we have many well described ways to protect the population.
Mhm.
If we truly are facing a lack of capacity, if that's why we're doing all these very stringent lockdowns, then why don't you build a whole bunch of military hospitals? You can put them up in a very short amount of time. Why don't you have patient hotels like they do around the world? Again, well described in the literature for all the patients who would be suitable for long-term care that
Mhm.
are currently blocking up a lot of the resources in the acute care hospitals because there aren't spaces in long-term care. You can have this as a stopgap measure. I mean, there are many solutions we have, but on the one hand, we don't want to face the solutions. On the other hand, we feel, well, the public seems to support this approach and it makes them feel safer, so we'll just shut everything down. Well, I get to see all the patients who are suffering from those shutdowns.
Yeah.
Many people in the community only exist because their daughter is able to check on them every single day. Mom, did you eat today? Dad, were you able to go to the bathroom? Mom, are you having chest pain? Now those relatives are being locked out of buildings. And so these people in retirement homes are ending up very, very sick. I've had a number of families actually end up passing away. A number of other people ending up having their surgery far later than was necessary, like on death's door, not for cancer, not because they got infection, but because they had a medical need that they were not able to get dealt with due to us focusing on one risk, COVID. That's it.
Yeah.
And not thinking about all the other risks.
Yeah. It's incredible when you hear these stories, and some of them have hit the media where patients truly are suffering, not because of COVID, but for other reasons. So I guess overall, I'm going to uh, summarize that you're a little skeptical that COVID's going to provide the impetus that we need to look at health reform. I think,
I'm hopeful. We have to be hopeful.
yeah,
Despair is not a Canadian virtue.
I think the answer is probably, I think you're right. I think we're seeing elected officials do what they've done for decades, and that is just simply assume that they need to throw more money at the situation rather than make systemic reform and look at how we can
They've got a hard job though. We need, like, I would not want, I feel so bad for anyone in leadership right now.
yeah.
Having said that, doing what we did before is not there's no excuse for that.
I think you're right. It is hard. It's easy for us to sit back and armchair quarterback these decisions. I fully realize that, but I'm just
Yeah.
not sure that we're there. I don't think the political class is there to really look at some of the systemic ideas, some of the solutions that you mentioned today. But I think that's why it's important for people to read books like yours and other articles and reports and so forth out there, and get more informed about how we could have better results for patients if we looked at different things. Now, I mentioned that you at the beginning that you had this book largely focuses in on the problem. I think of it as sort of like a dissection of a patient, right? You're figuring out all the different things that are wrong that contributed to the patient's health problems. Whereas your next book is really that you're working on mentally, I think at this point still, right? Is looking more at constructive solutions in that. Is that right?
Yeah, so I'm glad you put it that way. I think of this book as the diagnosis and the next book as really getting into the treatment. We introduce the treatment at the end of this book, sort of the last chapter, and we talk about concepts that need to be in place. So, for example, every single patient chart, if you go to your family doc or you go to the emergency department, we put on the top of the chart, we have a bunch of demographics. So it has your name, your date of birth, your phone number. But right beneath that, and equally as important, we have a spot for an emergency contact. So it can be your next of kin or your best friend, but we need to have a name there. So the literature is solid on this. Socially isolated patients do very poorly when they get sick. So it's not just a convenience for me. It's actually really important for you that you have some connection, especially when you're sick, especially when you're acutely sick. I would argue that it's equally as important when you have chronic disease. So you're going to need rides to a clinic, or you're going to need someone to change the cat litter when you're bedbound, or so there's a million little things that we need some sort of kinship or connection. We need an emergency contact, but not just in emergencies, we need it for ongoing care. So there are a whole bunch of things like that that are crucial to you getting the care you need, but they aren't really amenable to us writing a policy on it. Like, we can't really write a policy with a checkbox or something. Do you have emergency contact? Check. Do you have family member? Check. It doesn't work that way. Whereas we can make sure that we don't write policies that destroy that connection. So, for example, there was a case in the news, I believe it was out on the East Coast, where an elderly woman was kicked out of the hospital and got in big trouble for holding her husband's hand.
Mm.
This is during COVID, right? No, you can't hold her hand. You can't hold his hand. Well, we're doing something wrong when we make policies that completely undermine the basis of that essential connection.
Mm.
We're getting it wrong. Now, I'm not saying we need to now pass a policy saying everybody's allowed to hold hands. That's not the
Yeah.
point of it. The point of it is to understand the essential nature of some sort of kinship or connection and fostering that. And again, the literature supports that in spades. So, I mean, that's just one example. We can talk about peer support for physicians. We can talk about our sense of ownership, not the deed on the title of the clinic, but the sense that me and my staff have for this place that we work. We feel a sense of pride and ownership. It's easy to destroy that.
Mhm.
You go to your staff and one harsh word and they would say, okay, forget it. Colin, problem comes in, it's yours, baby. Yeah, this isn't my place. Clearly it's your place. Why should I be creative in finding solutions? Well, when we have a centrally run system, top down command and control flavor, where really smart people write these beautiful policies that clearly say, hey, Colin, Sean, you guys don't own this place. We're going to tell you what's good for you because we're experts. And they are experts, but
Mhm.
they certainly aren't experts at not destroying this vital sense of what ends up being I would argue, the key ingredient to outstanding care. Our patients get great care because we stay a little later because we have a sense of ownership and they're our neighbors and we have a sense of pride and we're connected to them. There's that kinship with them as well. All of these ideas need to be packaged into a policy approach that is not too fluffy or esoteric or philosophical. And so that's what I'm wrestling with right now. How do we put this into a book that puts it together into a package where people could pick it up and say, yes, why hasn't someone talked about this yet? And so it's coming along, and I'm really excited about it. And hopefully the things I just told you don't sound too outrageous.
No, no, no. It sounds like it'll be a good one-two punch for people. So I don't want to go too far ahead, but to come back to this book, my final question for you today is: how can viewers get their hands on this? Where can they buy a copy of this if they'd like to read it?
Well, thank you so much for, first of all, telling people about the book. I really appreciate it. It's available on Amazon, so amazon.ca in Kindle or hardcover. You can get it through Chapters as well if you prefer to go Chapters Indigo. It's at your local Chapters bookstore. Most people haven't, it's a terrible time to be trying to write a book and market a book in the middle of lockdown, but a lot of bookstores now are opening up. And then also you can order it directly from the publisher at Optimum Publishing International. It's on the book itself, and they'll ship it to you, free shipping, just like with Amazon. The reason I mention Amazon is because so many people shop with Amazon. All your information's there, so it's just a one-click purchase. But some people do the same with Indigo and elsewhere. So those are the ways you can get a hold of it.
All right. Well, thank you. And if you, for viewers, if you do get a copy, make sure you have a pen or you buy a pen, because there's a lot of good stuff if you're like me and you like to underline facts so you can come back to them. When Politics Comes Before Patience, the author is Dr. Shawn Watley. Again, Doctor, thanks for your time today, and best of luck as you continue to promote this book and start working on your next one.
Really appreciate it, Colin. Thanks. Have a great day.
Thank you.